Good evening to all of you. And if you're in somewhere in the South Asia region, or later in the day or earlier, it's a real pleasure to be here to kick off the second webinar in CDEP's 10 Conversations on Global Health. This webinar series was intended to celebrate the 10 years of existence of CDEP and to really draw the focus on areas that CDEP has worked on, but also areas that are particularly of importance to global health. And we're delighted to bring together a fantastic set of speakers for you today to talk about infectious disease challenges in the Southeast Asia region. Now, this report that we're launching today, which was now available on our website at cdep.org, was basically intended to draw attention to the challenges of infectious diseases in Southeast Asia, the WHO region of Southeast Asia, which goes all the way from India, covers small places like the Maldives, but all the way into to Thailand and Indonesia. And the purpose of this report was basically to say that there are challenges with infectious diseases, and also to recognize that a lot of the avertible burden of disease in this region continues to be infectious. Although we know that non-communicable diseases form the majority of burden of disease, a lot of that is still not yet avertible because it involves behavior change or it requires interventions that are not yet available to most people. But infectious diseases are actually avertible to a large extent, whether it's malaria or HIV or tuberculosis, to some extent, drug-resistant infections. We've had a long experience with these in this region, and there are parts of the world where they are no longer a threat. So, in that context, I'd like to first introduce our first speaker. We're delighted to have Dr. Soumya Swaminathan, who's the chief scientist of the World Health Organization. She's obviously a star in the infectious disease domain, having worked in tuberculosis for many years in Chennai, and was the Director General of the Indian Council of Medical Research. And she's here to launch the report and then talk about the challenges of infectious diseases, particularly in the context of COVID-19, which has to some extent derailed our attention to many of the other important infections that continue to plague the populations in this region. Over to you, Dr. Swaminathan.
Thank you. Thank you very much, Ramanan, and greetings to everyone from Geneva, especially to the panelists of today's webinar. I think it's an important document that has been produced and that's been released today because of the fact that the region, the Southeast Asia region, still has a high burden of infectious diseases. And of course, at the same time, we have the growing incidence of non-communicable diseases, as well as of accidents, injuries, and suicides. And so you really have a triple burden that countries have to deal with. This is in addition, of course, to all the maternal and newborn issues that are also very important. So the tendency, always is that you go from one extreme to the other. We've been focusing all these decades on infectious diseases, particularly the SDG, the ones that were in the MDGs, the Millennium Development Goals. But I think it's time now to take a more broader approach to health, because the underlying causes of many of these infectious diseases end up being very similar. So what we call the social determinants of disease, the risk factors, and so on. And the solutions also need an approach, I think, which has commonality. So maybe from the experience of the past year, I'd like to touch on a few, and these are my own personal reflections on a few areas where we need to start doing things, a little bit differently. We also know that many of the infectious diseases have vertical control programs. I mean, this is at the global level, but also at the regional and national level. So if you look at malaria, if you look at TB, you look at HIV/AIDS, these three in particular have vertical programs. And then for many of the other diseases, there's the vector control disease program as well, which now is moving to become much more integrated across different vector-borne diseases. And then for the diarrheal illnesses and so on, you have, of course, there needs to be a focus on, water sanitation, but also management at the primary healthcare level. So I think the first thing would be perhaps really think about universal health coverage for people. What does that actually involve? Where do the investments need to go? They need to go primarily to primary healthcare, to strengthening the primary healthcare system, both in terms of, having trained human resources there, whether they are nurses, community health workers, but supported by physicians, could be even remotely, now that there are opportunities that have clearly been demonstrated for telehealth services. You can actually provide better quality care even at the most peripheral level, which is, the center, sub-center that will be catering to, 5,000 people or so. And go further down as well to the village level, because of the ability to support through telehealth. So the second thing is what are the components of universal health coverage? And we often think about care delivery, diagnosis, and treatment, but we also need to think about prevention, health promotion, and attention to all the other risk factors and determinants of disease. We know what they are: their nutrition, safe water, sanitation, housing, uh, and quality of the air, both indoor and outdoor air pollution. These are all the major risk factors for disease. And these again cut across multiple diseases. They contribute both to infectious as well as to non-communicable diseases. And that aspect has been neglected. And the third area in community healthcare, I think, is the community engagement itself. And I think there are good examples in the region of where this has really been done well. And when we think about diseases like malaria and TB, it really needs solutions for diarrheal diseases as well, for indoor air pollution. The solutions have to involve the community. Very often the solutions could come from the community. They need to be involved in the planning as well as implementation and in the monitoring and evaluation of how well that's working. So I'm glad that the TB program is really now moving towards that in many countries, but I think a lot more needs to be done. I was involved in a project for malaria elimination in Madhya Pradesh in Mandla district, which was really based taking 1,200 villages, trying to eliminate malaria through a focus on, community-based solutions, really doing the surveillance, getting volunteers from the villages to do the house-to-house surveys, making sure everyone gets access to diagnosis and treatment, as well as, of course, the literacy itself, the health literacy and information about how to avoid malaria or how to detect it early. So I think, so that's one whole package of work, I think, which needs to be done. It's the resources that are needed for universal health coverage and the financial protection, but much more than that, it's the organization of services. And I think diagnostics are often neglected at that level. For COVID, we've seen now, in a matter of a few months, so many new diagnostics were developed, starting, of course, with RT-PCR, which needs a lab infrastructure, etc. But then now you have paper-based rapid diagnostic tests based on CRISPR and so on. We need to really start applying that to TB, and of course, the issue of which antigen to select, etc. And the fact that in the past we haven't had great luck with either antigen or antibody detection in TB. But I think this is an area where there's so much technology investment now that it needs to be looked at. And similarly, for the other diseases, we need point of care diagnostics to really have an impact. Then I think, so that's part of laboratory strengthening. The overall, use of an expansion of digital tools and technologies, whether it's been in the area of contact tracing, apps, mobile apps, whether it's been in the area of telehealth in India, the e-Sanjeevani clinics, for example, where specialists can connect with a community health worker or with a VHN in the village, because people and patients were not able to travel to the health centers. This type of remote care can now also be, there can be further innovations in that. This needs to be studied. So I think telehealth is one area where there needs more research and documentation of health outcomes. And I think that's something that we need to um, almost, it has to run across. I think the documentation of experiences, the what we call implementation science, implementation research is very important, particularly when new innovations are being introduced. We need to document. So again, involving researchers and academics, in the delivery of services is very important. So for telehealth, I think there's remote care, but there's also remote shared care. It's something that I was introduced to, about a year ago. I've seen it in practice. It's basically involving one healthcare provider dealing with many patients at the same time. And one can do this for diseases where there is no confidentiality issues, where people are willing, let's say a group of diabetes patients interacting with the care provider remotely, so through tele, but asking questions and asking, getting advice, getting counseling on that particular ailment. So this is something that can be tried because it saves resources, and at the same time, it actually helps patient to patient learning. And some people who may be very shy, not being able to communicate with their providers, may actually benefit from something like this. It's been tested for glaucoma by the Arvind Eye Hospital in Pondicherry, but we need to test it for more diseases. So that's digital. There are other innovations as well. Lots and lots of innovations that are happening in solar-powered oxygen concentrators is one example. Diagnostics is another one. Lots of technology that's being developed for COVID, and we need to really leverage that to see how we can use it for. I mean, there's a great need really in the area of safe drinking water, for example, and sanitation. Again, there's a lot of work going on in the region, but we need to ensure that this reaches people. And then I would say that the focus needs to be on data driven. Again, we had in COVID this whole debate between, do you go into a lockdown or not, and in the early stages, there was no other way, or when things get really out of hand. But the aim should be not to go into a lockdown, but really to be able to tackle the problem by knowing where the disease is, by knowing where the infection is, how is it spreading, where is it spreading, who's at risk, and taking action to focus your interventions in that area. So I think data is really, really important. Knowing where these diseases are. Is it the urban slums? Is it, rural areas? Is it tribal areas? And for each of these infectious diseases, you'd get a slightly different, but you would see many of these diseases, again, clustering, say in tribal areas. You would see that. Again, it's because of the social determinants that underlie. So a data-driven approach where you invest more resources in those places where there is least amount of, where there is a maximum disease burden and perhaps the least access to health will bring more dividends. And I think finally, I have to say that the whole model of research, the openness, the global collaboration, the kind of sharing of data, knowledge, genomic sequences, everything that we've seen during COVID needs to get replicated. And it really pains me when a TB vaccine that's been shown to have a 50% reduction in incidence, several years ago in a phase 2B study, still hasn't found its way into a phase 3 trial where, 50% reduction in incidence would be huge for a TB vaccine. And yet it hasn't happened. Whereas we've seen over 200 vaccines being developed for COVID, 8 of them already out there being used within a year of a new pathogen, and lots more investments in clinical trials, new platform technologies. We need to now leverage those platform technologies like the mRNA and the viral vector platforms in order to develop vaccines for TB, for malaria, etc., perhaps for some of the other neglected tropical diseases as well. And that was possible through, of course, you need funding and investment, but you also need this kind of a global solidarity and a single focus on the R&D, but also then on the equitable distribution, which is what we're doing through COVAX. So you need the R&D, you need the pool procurement and distribution mechanism. You have Global Fund, of course, for the 3 big diseases, You have Gavi for vaccines. We don't have anything globally for non-communicable diseases or for the other communicable diseases. So that's again something to think about for the future. But again, the countries that have a high disease, this could be at the regional level as well. It doesn't have to be only at the global level. So for the Southeast Asia region, there could be a model of an R&D public-private partnership that focuses and invests in tools and technologies to tackle these infectious diseases. Thank you, Ramanan, and back to you.
Thank you, Soumya. That was excellent, and I think a real key takeaway is the idea that COVID may have disrupted control of these diseases, but the urgency that COVID has brought to infectious diseases is a momentum that we should not lose. It's very clear that science is not the barrier to control of infectious diseases. It's really the willingness to use that science and deploy it, as has been done for COVID. If we can have 200 vaccine candidates for the coronavirus, why don't we have even a fraction of that for other priority pathogens? Is really a question that the world will ask now, and I hope that WHO will be able to leverage this moment to be able to do exactly that, which is to point out that tuberculosis actually kills more people than COVID, and therefore we should be doing something about that as well. And maybe have 20 vaccines for TB. So thanks very much. That was an excellent opening and sets the stage very nicely for the conversation. We're going to turn very briefly to a message from Dr. Poonam Khetrapal Singh, who very kindly wrote the foreword for this, for this report. This report actually grew out of conversations that we had had with Dr. Swaroop Sarkar, who was then the director of communicable diseases at the Gates at CRO, and this was also funded by the Gates Foundation. And I think it's all very timely now because it comes together in a context where COVID changed everything, and now we have an understanding of what we should do post-COVID that's driven by a new urgency for infectious diseases. So let's just watch this very brief message from Dr. Poonam Khetrapal Singh, who is the director of the Southeast Asia Regional Office of WHO.
A very good evening to all. It is a pleasure to join you to launch this very important and timely publication. For well over a year now, the region and the world have been battling the COVID-19 pandemic, which provides yet another example of the vast social and economic impact that communicable diseases can have. Throughout history, communicable diseases such as HIV/AIDS, tuberculosis, malaria, neglected tropical diseases, and enteric pathogens have taken hundreds of millions of lives, deepened poverty and inequality, reduced productivity, and stymied economic growth. They have impeded sustainable development and been a barrier to the right of all to good health and well-being. Though the region bears the world's second highest mortality rate due to communicable diseases, progress against them has in recent years been strong. An observation that is well made in the publication being launched today, which provides a comprehensive survey of India's remarkable advances across a range of programmatic areas. Throughout the COVID-19 response, recovery, and beyond, WHO will continue to support India's onward journey against communicable diseases, which must be defined by the conviction that all people should have access to the services they need without financial hardship. In other words, to achieving universal health coverage. Now, more than ever, the old binary between vertical and horizontal programming must be done away with in favor of a smarter approach that is focused on integrating primary level services while staying in mission mode where we must. I am inspired that this is exactly the approach that India is taking and look forward to our continued collaboration in pursuit of the region's flagship priorities, WHO's triple billion targets, and Sustainable Development Goal 3. I wish you all the very best for the launch of this publication and in coming discussions, which I look forward to being apprised of. Thank you.
Wonderful. So same idea from Dr. Poonam Khetrapal Singh as well, which is that we really need to seize the day, and I think that's really going to be the theme for the conversations that that go on for the rest of the hour. It's my great privilege to introduce the four panelists. All four were co-authors of specific chapters of the report, and they contributed their time to be able to make this entire thing possible, along with many others. We have Dr. Nimalan Arinaminpathy, who's going to talk about tuberculosis, Dr. Subhash Hira on HIV, Dr. Gagandeep Kang on enteric pathogens and typhoid, and Dr. Anita Kotwani on AMR. Their affiliations are in the invitation, so I won't go over their bios. They're all extremely well-known and internationally recognized experts in their domains, and it's a real pleasure and honor to have them here today. So what we'll do is I'll start with a few questions for the panelists, and following that, we will open that up for questions, and you can post the questions on the question chat, and we'll pass them on to the panelists. But first we'll start with some questions for the panelists, which is fundamentally, how has COVID-19 affected disease prevalence and efforts in disease control in your particular area of expertise in the region? And if I may add to that, what does COVID now make possible, which was not possible before because of the increased attention and awareness about infectious diseases? It could be anything from hand hygiene being more easy to implement because people understand it now, or masking in particular situations, which might be easier to get people to comply with now. So the basic question is, how has COVID changed the landscape for these four sets of diseases? So we'll start with Nim on TB, and then we'll go through all of the panels. So Nim, over to you.
Great. Thank you very much, Ramanan. And also thank you to the organizers for the opportunity to take part in this really great discussion. So for tuberculosis, I would say that at a theoretical level, at least, control of TB is actually quite simple. I mean, basically what you need to do is to find active cases of tuberculosis and treat them as effectively as possible, on the one hand. And on the other hand, for people who are already infected with TB, but they haven't yet developed active TB, the impetus is really to try and prevent those individuals from developing active TB, the dangerous infectious form of TB. And one of the clearest signs that we've seen from the COVID disruptions over the last year is the fact that patients are missing opportunities for diagnosis to even access treatment in the first place. And this is because of a range of factors. It might be to do with, for example, reduced access to care, reduced availability of primary care facilities, but also the patients themselves, not being willing to go out and seek care in the first place because of lockdown conditions. So one of the things that the India TB program has done, which is quite remarkable, is to make publicly available their data for reported TB cases. And so you can actually go onto the website and see, how the reported TB cases have changed over the last year. And it's striking to know that even now, at the time of speaking, the notified TB cases are 30% lower than what they were at their height just before the period of lockdown. And so India's lockdown, obviously did not last that long. And so the disruption that we're seeing to the numbers of cases being reported and then initiating treatment is lasting a lot longer than the period of disturbance itself. And so that means more TB cases in the community, more transmission potentially, and so on. And just one thing to add to this, I mean, you could say that perhaps this is something that applies to the rest of the world, and indeed it does. I mean, we're seeing that these TB disruptions to TB programs are pretty widespread, but one particular thing in the Southeast Asian region that's quite relevant is the preponderance of the private healthcare sector. So if you think of a person at home with a cough that's been lasting for the last few weeks or so. And when they go to see a primary care provider, the vast majority of the time that'll be in the private, that'll be a private healthcare provider. And we know that the private sector has been really badly affected by lockdown conditions and also has not fully recovered back to normal as well. And so one of the really important challenges going forward is going to be for even the publicly funded, administered and run TB programs to also assist the private care provision of TB to get back on its feet as quickly as possible.
Thanks, Nim. Dr. Hira?
Okay, thanks, Raman. And I think it's, as Soumya said very rightly, that I think it is so timely to have brought up the infectious diseases back onto the visibility areas because of COVID having diverted all the attention, which rightly, of course, so. But just to bring this, what has happened to HIV/AIDS and the STIs as a result of the global pandemic that swept across. And what we see across is exactly what happened about 5 years ago. I was doing a look at the corona cousin, which was causing Ebola in the Central African, West African countries. And I and Peter Piot, we did a very quick in-depth study to look at what happened to the health system as a result of Ebola. And all that we at that time saw is happening and repeating again now on the global platform. We are looking at that even if the prevalence of HIV/AIDS across the globe remains like across, say, United States remains at 0.8% amongst the COVID patients, the prevalence in Africa is about 20 to 25% of HIV people, but that's the usual general prevalence. So nothing really has changed much as far as HIV/AIDS is concerned with the incoming COVID infections. What has doubled is the mortality. The mortality rates amongst dually infected, those who already are HIV/AIDS and have COVID now, the death rates have gone up and they are likely to go up even when there are many more comorbidities, because there are many more comorbidities that we are seeing in dually infected individuals. At the same time, we see what is moving more rapidly towards is the number of cases that are appearing, and also at the moment as it is, the antiretroviral therapy is continuing to show no major concern, but then we are anticipating that as we move along, the antiretroviral treatments, both from the first line, second line, and third line, are likely to be facing more resistance. So in this case, just give me a second. I seem to have a battery problem. Okay, so I think if you spread it around, the fundamental issue here is the
Subhash, your mic is muted. Yeah, now we can hear you. Oh. Yeah, we can hear you now.
Okay, I'm sorry. So I was talking about the fundamental of 90-90-90, the target of HIV/AIDS, that has got disrupted. And there is a major concern globally that if this remains disrupted for too long, every 3 months of disruption in the first 90, that means people start knowing their HIV status. The second 90, where people who are HIV positive will get treated, and the third 90 where people are treated and remain virally suppressed. Now, if this 90-90-90 became disrupted because people are not able to get to the hospitals to get their refills every month and then get the viral load testing done to know what's happening, whether they need to move from antiretroviral resistance to the next level, there is going to be an excess of 500,000 deaths in Africa. And Africa is already now counting that those who are dually infected with AIDS and COVID and have not been able to go back for their refills to the hospitals, not been able to go back for the monitoring the viral loads, there are very high levels of deaths. So I will stop here. There are major areas where we would be concerned that where there are dual infections, HIV and COVID, then there is the triple whammy, and that is HIV, TB, and COVID. So I think we're sometimes now looking at so much of permutation combination. So great, I'll stop here. Thanks.
Thank you, Dr. Hira. Dr. Kang.
Thanks, Ramanan. So if we think about enteric infections and include typhoid in the enteric infections, these are not called neglected tropical diseases, but they are neglected among infectious diseases, because if you look at what gets tested and for what determinations are made of the burden of disease, I think respiratory infections are prioritized now way over diarrheal pathogens. Particularly in countries like India and most of Southeast Asia, it's so much easier to treat a diarrhea or treat a fever than to figure out what actually causes the fever. So as researchers who work in this area, we spend a lot of time actually generating burden of disease estimates, because that's the only way. Doing these prospective studies is the only way that we're going to have answers about how important many of these pathogens are. If we look at what has been happening with COVID, the one thing that has changed is the ability to do PCR in every part of the country. If we think about where PCR adds value, it really adds value to the detection of infections for which the cost of a PCR is less than the cost of treatment. So still no joy for diarrheal diseases, but possibly we could consider that maybe typhoid people would want to try it, except that PCR is a really bad diagnostic for typhoid. So in terms of moving forward our agenda of bringing diarrheal diseases and typhoid front and center, COVID has not helped at all. If we look at what are the strategies that can be used to control these infections, which while they are neglected are still contributing quite significantly to global burden of disease, there are some things that are tried and tested. Early breastfeeding, continued breastfeeding for 6 months continues to be emphasized. You mentioned WASH and the possibility that we could have better hand hygiene, driving down enteric infections. That is a hypothesis that I would love to test, because I'm not sure that the WASH message has percolated to the places where we see the greatest morbidity and mortality due to enteric infections and typhoid. One thing that we have been working very hard on, and while we continue to work on water safety, on sanitation and hygiene, and these are critical for changing what happens with enteric infections in the long term, we have also been looking at vaccines. We've had a really successful program with the rotavirus vaccine. And we've been thinking about whether we should be talking to the government about cholera and typhoid vaccines. The problem now is, where will these find space in the budget? given the amount of funding that is being spent by every country on COVID-19 vaccines, the few countries in the region, Nepal and Bangladesh, had begun to discuss the possibility of cholera and typhoid vaccines being rolled out in national programs. And I'm really worried that these might be off the table if countries don't have enough budget for them. Certainly in places like India, since we are graduating from Gavi, while for Bangladesh and Nepal, it might be a possibility that they will continue to consider this. The other areas that I think are important to think about is AMR, particularly for typhoid. And this is an increasing concern in the region. We had the extensively drug-resistant strains in Pakistan. And in the last year, we have begun to see third-generation cephalosporin resistance as well as azithro resistance in strains from India, which makes it even more urgent that we continue to track what is happening with typhoid and think about interventional strategies. One area that infectious disease folks don't discuss very often, but WHO certainly does, is food safety and the requirements for food safety and what it means for enteric infections and for typhoid. We have very few systems in India and in many parts of the region that have surveillance mechanisms looking for food contamination. There have been efforts recently with the regulatory authorities to build those out, but the kinds of quality laboratory systems that you need for such activities are not yet in place. As with everything else, my biggest worry is that COVID is such a sinkhole of funding, resources, energy, that it's going to damage pretty much everything else, and other infectious diseases will be the worst affected. We've seen, just like Nim said, with the TB detection rates, the same thing is happening to vaccination programs. And I'm waiting to see what happens to children's nutritional status, given that they've been out of school and midday meal programs have been significantly disrupted for very long periods of time. So I'll stop there and thank you.
Thanks, Jerry. That was excellent, and certainly a bit depressing. You're right. This is going to suck the oxygen out of the room for some time to come. And now we turn to Dr. Kotwani for her thoughts on AMR. You're still on mute.
Yeah, thank you, Raman, and thanks a lot for giving this platform to AMR at least, because AMR is one, it's not a typical infection or a disease which is known so well, and it has not been recognized by the policymakers till recently. AMR is actually a pandemic, though it is a silent pandemic, but it is unnoticed by general population until very, very recently. Even governments were not ready to accept that AMR is a real burden on governments and on infection or on the healthcare. But though they have realized very recently, they developed their national action plan in 2017, but then came, as everybody said, 2020, and everything, the attention of the world was diverted to COVID-19. And the entire workforce, everything was hijacked by COVID-19, and nobody was talking about AMR. So the true picture of AMR during COVID-19 is still not very clear, because it will be clear after a few months or years when the data is there. But we can really appreciate what went wrong or how antibiotics were overused during COVID-19, which could have favored the AMR. Like if we see the antibiotic use in hospitals, it is said that about 70% people who were hospitalized with COVID-19 were given antibiotics. COVID-19 patients also received some broad spectrum antibiotics. And then there was so much use of azithromycin and teicoplanin. But later on, it was realized that only 7% or 8% of COVID-19 patients develop bacterial or fungal infection. But the latest report says that 72% received antibiotics. And in our part of the world, that like in Southeast Asian region, it would be somewhere more than 70% also, because there were no treatment guidelines, there were no access to experts and even to culture reports. So people were using right and left broad spectrum antibiotics, and azithromycin was used in hospitals also. So this all favors in increasing the AMR. Now, even there must have been some lapses in infection prevention control in hospitals during COVID-19 because our healthcare workers were not so many in Southeast Asian region, and they were not trained also. And then healthcare workers were more concerned about, and rightly so, for self-protection, universal glove practices, etc., that maybe there was some cross transmission among patients. So that again would have given some rise in AMR in the hospital. Similarly, in community. Now, as we all know that AMR is the major driver is inappropriate use of antibiotics. In community in Southeast Asian region, as such, there is a lot of inappropriate use of antimicrobial, and they are available over the counter. People can go to the retail pharmacies or any vendor and take without a valid prescription antibiotics. And more so in COVID-19, especially after immediately after lockdown, people just, because OPDs were not running, primary healthcare centers were not there, people were reluctant to go to the hospitals, and people bought all these antibiotics from their retail pharmacies. And retail pharmacies also, on their advice, give them prescription. When then the report came of that azithromycin is used. So in our part of the world, people started buying azithromycin and keeping in the house. And with a slight symptom of any sore throat, azithromycin was popped by the patient. So as Dr. Kang said, that already there is a lot of resistance to azithromycin. And if we are using one particular antibiotic in large quantity, definitely it is going to have impact on the AMR, especially for a particular bacteria. So this is a cause of concern that COVID-19, there was right and left antibiotics were used, and there was no concern for AMR because the major attention was just to give anything to patient. And then in community, there was a lot of use of sanitizer also and some biocidal agents. Again, that will also go to environment, and that may have increased the AMR, which we'll come to know later on. Now, another part is that though recently there is some data from India which says that the sales of azithromycin and some other antibiotics really were huge compared to 2019 and 2020, but this data needs to be published recently. Now, coming to the other part, a little bit, I'll say that what went wrong, which was not done during COVID-19, which must have impacted or affected AMR. One was immunization program. That routine immunization program was again hijacked, especially during lockdown period. And after that, after opening of lockdown also, this was not 100% as it used to be. So that will also impact AMR. And then, as I said, that very, very recently in 2017, all these Southeast Asian countries, they developed their national action plan on AMR. And some countries had begun something, and those all activities are now in the back burner. So nobody is talking about the AMR activities, but are talking about AMR. But that is a very good platform which we have started. The momentum of COVID-19 awareness, etc. I'll talk in the second part that how we can pick up from all those things which we have learned during COVID-19. That's it from me. Thank you.
Thank you so much, Anita. Very comprehensive and certainly covers a lot of things that we really ought to do. But I'm now going to go back to the panelists and ask you to just spend just a minute on on just one question. If you had to offer advice to the ministers of health in countries in the region, what are the top 3 things they could or should focus on in order to be able to regain control of your specific infections, the ones that you're covering, over the next few years in their countries? What are the top 3 things they should immediately prioritize? So we'll start again with Nim.
Thanks, Ramanan. So for tuberculosis in particular, I mean, I'm particularly encouraged by the recognition that tuberculosis had even before COVID. And we've touched a little bit on, the COVID drain, as it were, in terms of research, but also financing. And just to elaborate on that, I think the important point will be not to lose sight of the long-term priorities, because if we were to look over the next year, 2 years, 3 years or so, I would tend to agree with folks who think that COVID-19 is probably not going to go away, but is going to become more domesticated. And it wouldn't be the source of global mortality that we're seeing today. And so, we would be looking at the kind of annual seasonal respiratory virus that we usually have to put up with. And quite similar to the other human endemic coronaviruses, for example. But when we talk about all the other diseases we're considering today, TB, HIV, diarrheal diseases, AMR, these are long, slow stains on, in terms of public health burden that are going to persist regardless. And to some extent, as we've heard in these various ways, have been exacerbated and they've not gone away. And so I would urge first to maintain a view of those, those persisting priorities, as it were, over the next few years. In terms of TB, as I mentioned, perhaps the main problem that we're facing at the moment is this expanded pool of patients who have been denied opportunities for diagnosis. And so one of the really important things would be then to try and catch up on those missed opportunities for diagnosis. And this may involve what in the field we call active case finding, which is going out into the community to proactively try and diagnose TB cases. But at the same time, it would also involve other measures, for example, to reduce the stigma around respiratory disease, which would have been particularly intense now with the emergence of COVID. Basically, as many measures as we can bring to bear on the single goal of catching up on these misdiagnoses. Of course, we're asking programs to do this at a time of severe programmatic stress, and so it's going to be a very tough ask. And so I think this, this is also going to be perhaps not just an ask from the ministry, from the health ministry, but also from the finance ministry and from international donors that we need to maintain. And this is again, touching on something that Dr. Kang mentioned earlier. To avoid the COVID drain in terms of the resources that are going to be available for our response to all of these other diseases.
All right. Thanks, Nim. Dr. Hira, very briefly, what are the top 3 things that you would do if you had to advise a minister?
Yeah, I think this HIV/AIDS basically is a lifelong infection. We don't have cure yet compared to what normally we have for tuberculosis and some of the other infectious diseases. So what is important is that we have to make sure that all the clinical services, the supplies and the monitoring, everything has to be put back in an easier paradigm for the patients, in a way that the patients have to be either through telemedicine get reconnected, because this hesitancy that we saw in Ebola lasted for more than 3 years, with the hesitancy of going to the healthcare services. Now, COVID is not yet over yet, so we're still talking about a long way where most of our infectious disease patients on lifelong therapies would go back to the hospital. So we are talking of more home-based services. We are talking of an enormous level of mental health issues that they have in terms of depressions, their financial difficulties and things. So they will probably have to have counseling by the home visits and some changes where people can go and get their point of care testing done. So 3 things important: services on telemedicine, 2 is counselings at home visits, and 3 is point of care and drug supplies.
Thank you so much. That was excellent. Dr. Kang?
So, given enteric infections and to some extent typhoid are problems of the environment, I'd say I'd focus on the fact that a rising tide lifts all boats. So let's go with, I think for care, it has to be an emphasis on universal health coverage to make sure that we build stronger health systems that can provide near to people the kind of care that they need for acute management of illness as well as preventive services. The second is a focus on WASH because I think WASH is expensive, WASH is long-term, WASH is a huge challenge, but we know what WASH did in terms of changing the way people lived in other parts of the world, and there's no reason why LMICs should not be emphasizing that. And then the third part of it, of course, is focus on vaccines, because when you can prevent diseases, why have them?
Excellent. Good points. If we get the money for the typhoid vaccine, that's certainly high on the priority list. Anita?
Yeah, I would say that we need to pick up the momentum of COVID-19 for awareness program, because the awareness program was COVID-19. At the end of the day, yes, it has picked up. There are multidisciplinary teams in it. There are celebrities. So we have to weave the AMR awareness along with COVID-19. So, and there is a strong evidence that if there is a good awareness program and it is linked to the reduction in antibiotic and appropriate use of antibiotics. So I will say this is an opportunity for AMR so that the same program can talk about AMR also. And we should not use the word AMR when we are doing general population awareness. It could be antibiotic resistance, because I have done a lot of studies in all Southeast Asian countries. They're the general public, pharmacists, journalists, they are unable to understand what AMR is. So in a simple, very local, contextualized way, some innovative and simple awareness program taking One Health. And I think the teams are the same with the Minister of Health and other intersectorial committee who are with COVID-19 and who are on the NAP AMR. So it can be woven together. So this is one, awareness for general population. Second could be strengthening of immunization, routine immunization, along with other immunization. And the third thing would be expanding primary healthcare services through telemedicine or increasing the timing. Somewhere the access to primary healthcare needs to be increased in the coming years, because then patients will go to this primary healthcare rather than buying antibiotics or going to a pharmacist or an informal dispenser, from where they get lots of antibiotics and all inappropriate. So I think these 3 things will have impact on AMR.
Thank you so much. I certainly strongly agree with all of those. I don't know if we still have Dr. Soumya on the line. Soumya, are you there? A couple of questions that are specific to you. Okay, but maybe Nim, you can address this, which is about this comes from Dr. Swarup Sarkar. The WHO framework of UHC does not recognize the need for early target reaching for communicable diseases in order to be able to reach the 2030 elimination goal, whereas UHC can be reached by incremental increase. How do you reconcile this?
Yes, thanks very much for the question, and it's a really important consideration. So I'm going to say in short, UHC is going to be really important for the future of the TB response, but we can't wait for UHC in order to accelerate the TB response. And exactly as the question suggests, there's going to have to be a lot of upfront investment in order to accelerate the current slow declines that we're seeing. And necessarily, I think in the short term, at least, this would have to operate within, the vertical programs that we're seeing. On the other hand, a lot of the considerations that are prevalent in UHC, I think are also going to be quite relevant for TB. So for example, for TB patients, one of the really pressing concerns at the moment in terms of how to improve TB control is the amount of catastrophic expenditure and the amount of, the incidence of poverty that happens as a result of TB. And so by addressing these issues, over the next few years, then perhaps TB and other similar diseases could also show the way for the implementation of UHC that may come later. But what I hope to see is that eventually we'd start to see high quality TB services being delivered throughout the healthcare system rather than simply through our dedicated vertical programs right now. But that would be a long-term convergence.
Right. Great. So, and another question which I direct to both Dr. Hira and to Dr. Kang, in some sense, India and some countries in the region were able to do contact tracing in a strong way because of the experience with HIV and I guess possibly TB as well. I don't know how much contact tracing that actually happens for tuberculosis. How much do you think this capacity has helped India, and how much does the COVID response itself help us with contact tracing backwards? Like again, we've now had this capability in place like UP, which I don't think did much contact tracing before. Are there state capacities that you think have been built up that we can deploy for other infectious diseases? I'm referring to contact tracing.
Sure. Yeah, I think you're very right. The contact tracing that has happened with COVID is extremely great. I think multiple states have gone through, did well, and I think one can use it for HIV/AIDS and strengthen it now because there's a lot of stigma around all these contact tracings have reduced, although it's not out of the blue. But people have to eventually get to this contact tracing more acceptable level.
Great. So actually, Dr. Kang, before you answer that question, I guess the real question which came from someone in the audience is, are there efforts to map the spillover of emerging resistant pathogens between sectors of human activity and regions and countries? So I think this is a good place to end the conversation, which is, we constantly get asked, including from the ministries, what is it that we can do in the future to prevent the next outbreak? And there's obviously many things that can be done, but what do you see as critical things that can be done from a scientific and research capacity? If someone was setting out to, do a PhD or build a career on this, building on the COVID pandemic, what might you advise them to do, which is more cross-pathogen rather than just about, one, a single disease sort of a perspective?
Well, obviously, it has to be surveillance, because if you don't know that you have a problem, it's very easy to ignore it. So if you have surveillance that tells you about the extent of AMR, what kinds of pathogens are circulating in your people, in your animals, in your environment, then you have a better sense of what you need to be working on. It's the basic principle of, if you measure something, it matters and you can monitor it. If you don't measure it, it's not there.
Right. Well, with that, I'd like to thank all of the panelists and also to Dr. Soumya and to Dr. Poonam Khetrapal Singh for joining us today. That was an excellent discussion. And, the whole thing will be available on Facebook Live as a feed, as a recorded feed after this. We'll be back with a webinar in March on the topic of vaccines and AMR. And then after that, a few more. You can see April is nutrition and long-term economic consequences, May on international cooperation addressing AMR, and June is on vaccines and long-term economic consequences. So stay tuned. We hope you're able to join us for the remaining webinars as well. Thank you all very much for joining and for your questions. And thank you again to the speakers who joined us today. Have a wonderful evening.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.